Hi, we are Community Dental Care, and my name is Kara Richard. I am our Director of Community Health Programs, and I have been with Community Dental Care for about 2 years now. And I'm going to pass it along to Dr. Shivan.
Hi, Dr. Shivan Nelson. I'm our dental director, and I've been with the company it'll be 15 years next spring.
Good afternoon. I'm Crystal Yang. I'm the Director of Development, and I've been with the organization for 16 years. And actually, I first encountered community dental care when I was a young child as a patient. So I get this wonderful privilege of serving in this role and serving my community. And today I get to share an organization overview about our mission and our services. So our mission is to provide culturally sensitive oral health care, preventive education, professional training, and to advocate for access for all. And you'll see here our 5 dental clinics. We have clinics located in Buffalo, Rochester, and 3 in the Twin Cities, Crystal, Maplewood, and our newest clinic we just opened this July, our Carlton Street Clinic. We have together 106 dental operatories, 302 employees, which includes dentists, advanced dental therapists, hygienists, licensed dental assistants, health educators, clinical support staff, and administrative professionals. We also provide oral health education and preventive dental services in more than 40 community locations, which you'll get to hear more about with Kara. So who do we serve? The vast majority of the patients that we are serving are on Medicaid or uninsured. A lot of the patients that we serve as well are from communities of color. More than half of the patients we see are children, and we are always serving new patients and welcoming in new patients of record. And we see emergency patients daily at all of our clinics. We also see a vast number of people coming from different counties, 72 of the 87 Minnesota counties. And we're on track this year to see 120,000 clinic visits. And as you may have heard earlier, dental health disparities exist, as you all know, in the communities that we serve. And we exist to serve the underserved. So we know that people living in poverty, they suffer twice as much tooth decay as their more affluent peers, and their tooth decay is more likely to remain untreated. And as you all have heard, access to care is limited. So only about 30% of those that do have public insurance are accessing dental care in a given year. So we've been able to grow over the past 20 years by expanding new clinics and building spaces where we can welcome all ages and children, seniors, and families, because we want to become their dental home. So you'll see that we've been able to grow over the years, and that with our newest clinic, we'll be able to see 140,000 patients once we're fully staffed there. And we have, as you may have heard earlier, 40 dental operatories, 2 floors at that clinic. And I'll just share a little bit that we do operate economies of scale, which you'll hear more with Dr. Shivan. And so our clinics are large in size so that we can serve all those who need us. And here's a map that shows the geography. You'll notice that the counties with the higher shade are where we see more of the patients in concentration, where the clinics are located. So you also note that patients are driving far distances to be able to access services at one of our clinics. And I'll pass it on to Dr. Shivan now.
All right, you guys see a lot of the same patients we do, so just to kind of ground everyone in kind of what barriers are our patients seeing. Obviously, patients have significant financial barriers to care. They're uninsured, they're underinsured with regards to dental coverage. They can't afford childcare. They've got the insurance, but they can't afford to pay for someone to watch their kid while they get an appointment. They don't have reliable transportation to attend appointments, particularly if they're coming from one of these out-of-state counties. You know, you need a reliable vehicle to get you there, especially in a Minnesota winter. Patients don't always have that. Or just they can't take time off work. They've got the insurance, they have a ride, but a day in the dental chair means a day of missed work, and that's not always possible for our patients. Our patients have a lot of administrative barriers. Many of our patients have a language or cultural barrier that make it difficult to navigate the U.S. health system. I'm a medical provider, a dental provider myself. My native English language is English. I still can't navigate health systems sometimes, so how do we expect our patients to do that? And then if they do need specialty care, very few specialists statewide take the Minnesota healthcare programs. So, and if those who do, there's often understandably a long wait to be seen. Thanks to a place like Smile Ortho that do take it, but there's just not enough to meet the need. And then the health plans on top of that, there's administrative barriers within the healthcare programs, as you guys are well aware. Some require prior authorization where they can't get that treatment the same day, so then they have to come back, or sometimes we have to need more information, and that can delay their care as well. So just lots of barriers our patients face every day. And then on top of all of these, our patients often have physical or emotional barriers to care. Mental health issues, sensory issues, dental phobias can discourage patients. It's not fun to come to the dentist. Physical disabilities or medical conditions that make it hard to predict how they're going to feel that day or physically get them to that appointment. In addition to these complex medical histories that can make just managing their care more difficult, and that can be they have lots of medical conditions, but it can be more than that. It can be, history of trauma. Some of our patients are in marginalized communities where a trauma may prevent them from, being in the dental chair is very vulnerable. Or they're from historically marginalized communities who maybe haven't had the best relationship with healthcare settings. So these are all just other barriers. So I'm going to talk about barriers and kind of what we're doing to hopefully address some of them. So kind of how are we addressing these barriers? And I just want to acknowledge everyone in this room is working on this. Every time I go to a meeting like this, I learn a little nugget from you guys. So this is probably a lot of stuff you guys are doing too, but I learned so much from you guys that we wanted to kind of say, okay, what's working for us? Maybe there's a nugget that someone else out there can take from all this, but I learned so much from you guys too. So this may be stuff but here's what's working for us. Offer flexibility in our schedule. Some of our clinics are open till 9:30 at night, and so that makes it where they can come, before work, after school. That can be really helpful. We offer walk-in and wait for urgent and emergent care. So pretty much all of our clinics all day long, we just have a column of people waiting to be seen, and it's like urgent care. Sometimes they're in and out in half an hour, sometimes they wait for 4, but we always have that option for patients that for whatever reason scheduling is just an undue barrier for them. And our clinic locations are all located on bus lines, helping to reduce travel time and cost. I will note another thing as far as our flexibility in scheduling. We don't dismiss patients for failing appointments. I know a lot of clinics completely understandably, especially if that new patient, they don't show up a couple times, they're not allowed to become a patient there because they want to be, offer that opportunity to someone else who's going to use that appointment. What we have found works well for us is they get a couple of strikes. Sometimes we get to a third, but essentially if they don't show up for 2 visits within a year, they're put on a walk-in wait. Say, hey, you can still come in. We're not going to give you that appointment spot until you've earned it back. So they walk in for us and they have to sit and wait. And hopefully they're seen that day, but even if they're not, they say, you know what, you've been here for 2 hours, Ms. Johnson. I don't know if we're going to be able to see you today, but we're going to count this. Thank you for showing up, and kind of help fill those gaps as we have them. So patients seem to receive this well. So just, you have to have accountability for patients, but also offering as much grace as possible. And so that seems to work okay for us. And we do warn our patients ahead of time. This is our attendance policy, so they're not kind of blindsided by that. So, and then of course we accept all the state healthcare programs. We offer a sliding fee scale for those that aren't insured, and we offer some care grants and also to get some urgent care done if they simply can't afford it. And I'll let Kara talk about the care grant. She's kind of our expert on that. So.
I am. All right, so we offer care grants, especially for uninsured or underinsured patients, just especially in those emergency situations, but occasionally in preventative and restorative as well. And really the goal of these grants is to eliminate those barriers, but also like if they are in pain or they have an active infection, we are taking the time and the resources to get them out of pain and stop any potential future concerns by offering these grants. So our most common one is our CARE grant, and this is specifically for children up to age 18, and then those parents who are unable to cover the cost of service. So we're specifically targeting families that are at an income at 120% of the federal poverty guidelines or below. And this is for any kind of emergency dental disease. And since they're children, we will occasionally then use them for preventative as well. But we're really taking this opportunity to identify someone who comes in the door and they're in pain and they're a child, and obviously they don't have complete control over how they got to us or what led to these circumstances. Let's get them out of pain today and try to really take care of them so that hopefully then we can establish preventative services. But at the very least, someone walks out of the door not feeling that toothache that they did when they came in. We also then offer emergency grants for adults, and this is the type of grant that really works with acute dental disease. So the other one, we might do some preventative services as well. This is specifically for that dental exam, x-ray, and then any kind of care that needs to be, the palliative care you need to get them out of pain today. And we really work then at the discretion of the treatment coordinators who are talking with these families and patients, or the clinic manager, or occasionally sometimes I will step in and just get them in and get them the emergency care that they need. We offer a couple other grants. So I oversee a sealant program based in schools, and this sealant grants covers all of our community outreach programs for anyone uninsured or underinsured in these programs. So we don't ask for any form of payment from families. We do, I'll explain a little further, but for anyone who is uninsured, we just take care of everything. And those things can include screenings, fluoride varnish, sealant, occasionally an x-ray, an exam, and then when the sealant grants also cover our medical dental integration that you learned about earlier with Fairview, and then we might include SDF on that as well. And then our final one is specifically for underinsured, so it can cover up to $100 of copay for those who have insurance, but maybe they just can't afford the copay today, but they have treatment that they need. So that's kind of the variety of care grants that we're able to offer to those who are either uninsured or underinsured. Do you want me to take this one?
I can jump in. That's
Okay.
And I'd say for our care grants too, we do a lot of independent fundraising for that in addition to some grants through the state. So it's kind of how we address financial barriers, addressing language culture barriers. Like we mentioned earlier, our staff represents the communities we serve. Our staff speak 30 plus languages. So obviously we try to get that interpreter in the door, but if we can't, there's usually someone we can get on the phone or someone from the front desk who speaks Korean, Burmese, Somali, you name it. It took me a while to count up all those languages. To kind of just make sure they're seen. And just, again, you got someone who speaks that language who's from the same community, sometimes there's just barriers that you're just not going to step in because that person just kind of more intuitively knows kind of how to have that conversation with the patient. And we work to build trust in these communities we serve. We hire from these communities, we do outreach in these communities, we live and we exist in these communities, from school programs to local food shelves to community centers to soccer tournaments. We try and really be where our patients are so they have that familiar face before they come into the dental office. And then training our staff to provide culturally sensitive care. We have little in-services and we have emails that go out every month, and we have trainings for all of our staff just helping get at some of those cultural differences. How do we be respectful of a person's religious beliefs or cultural practices, and so we can provide that care in a way that's respectful of that. And then we also provide access to on-site health educators to help improve patient and parent understanding. Sometimes it's nice to have a place outside of that scary dental chair to have these conversations, perhaps in their native language, where parents feel like they have the time and space to really deep dive into, okay, why does my kid need this care? Ask questions that may be afraid to ask the dentist or the person in authority. It just kind of gives that safe space to have those conversations more candidly and without, again, the same time constraints. And then another way we address the administrative barriers is we are never going to replace specialists, but we try and offer as broad a scope as procedures as possible. So we can save those referrals for when we really need them, but be able to keep as much in-house as possible. And we do that by offering a wide variety of procedures and services in office. And we do that by we mentoring our providers to ensure that they're comfortable performing. We want them all to be confident and competent at these procedures. And really part of how we make that happen is our larger group setting helps us to have that fertile ground for collaborating. If I'm one of 8 dentists on and I know I've got 2 dentists that day that are exceptional impacted thirds, I might be more likely to take on that case that day than if it's just me or one other dentist. So I think some of it comes down to our size too and the people we employ that have that mentorship just culture built in, that I think it makes our newer docs a little less scared to kind of tackle some of these things and know they'll have the support. And this is just kind of a list of, again, kind of comprehensive care we provide, particularly quite a bit of oral surgery and endodontics, so that I'll kind of get into a little bit more. Providers, and so again, it's all about accessing these barriers. Our patients are complicated, so we have to prepare our staff to handle these complicated cases. So there's, again, ongoing training and support. We have monthly doctors meetings where we bring up clinical cases and we talk through, hey, we had a such and such case at one clinic, let's bring it to all the other clinics. What did we learn? So making it a really safe space for our providers to share their successes and their failures. I think you have to be really open for that to be able to learn and grow to meet our patients' needs better. So for our medically complicated patients, both physical and mental illness, we regularly discuss these at meetings. We have the admin support, which I can't underscore this. If I've got a patient with a really complex medical history, I'm gonna have to get on the phone with multiple medical providers, and I'm doing that all myself, it's going to be a little more tempting just to refer out that patient than if I know I have the administrative team that say, okay, Dr. Sean, what questions do you need? Okay, if I need to get you on the phone, but they can take the kind of the heavy lift of that for me, it's just going to make sure, and then kind of make sure we get those consults or whatever we need back. The administrative help, so our doctors can really focus on the clinical side of things is really helpful. And then, we have clinic protocols in place. How do we handle, what blood pressures do we decide? Or okay, how do we handle anticoagulants? We have these clinic protocols, especially our newer providers can reference back so they feel comfortable, again, tackling some of those trickier cases in clinic. And then new to our Carlton Street that I'm really proud of is we now have bariatric chairs. A lot of dental chairs, the weight limit is about 350 pounds. That's not very much. So there's a lot of patients that we could have seen, but for the safety of the chair. So I'm really proud now that we have these bariatric chairs at our Carlton Clinic if anyone needs to refer anyone. Other ways we address this is patients with significant dental anxiety. I think an earlier presentation just talked about, that treating patients with kindness. Sometimes that little from that smile on the front, the person in the front's face to just how we make that patient feel comfortable in the chair. So really cultivating a culture of empathy with all of our providers. Things like we offer nitrous, music, a pillow. Can I get you a blanket? Can I turn on a movie for you? Patients are able to request to see the same provider if they're building that trust. Sometimes have that continuity of care is really helpful for building rapport. If they have, they can request providers that say maybe have additional experience in a certain area. If they're a cancer patient, if they're a former assault victim, if they have a sensory need, we have providers that have a little bit more training in how to provide that care in a sensitive way so they can request someone who maybe meets that special need they have. And then of course our healthcare educators can offer non-clinic spaces, again, to kind of have those conversations when they're not tipped back in the chair and vulnerable and they just want to get out of there. So I think that can be really helpful for alleviating that anxiety. And then our patients with sensory needs, we partner with Fraser, and I know they're partnering with a lot of organizations out here to just give us a little bit more training on how to ask and accommodate patients with sensory needs, whether it's dimmable lights in our rooms, closed rooms, ear coverings, little stress balls, toys in the operatories, kind of whatever we can do to help make that patient more comfortable and be able to kind of know the right questions to ask about their needs ahead of time. I know has been really helpful for our team. We also have an app, the Mimi app. Maybe some of you guys have this on our website that helps create that social narrative. So if that kid's coming in, this is what our front desk looks like. Here's what the chair is going to look like. You're going to open your mouth. Here's the tools we're going to use, and really help for young children and those autism patients that they can have that social narrative long before they ever come in the chair. So that's been really helpful for some of our patients. And then of course for our pre-cooperative and uncooperative children that just aren't there yet, our staff and providers are all trained on current AAPD guidelines for protective stabilization. Again, it's not something you want to do every day, but if you've got a little 2-year-old in pain, you want to be able to safely treat them that day. Again, nitrous music, movies in the operatories. We kind of train all of our staff on how to make things less scary. And then we also have hospital privileges as 4 local clinics and surgery centers for those kids that they do need sedation to be treated. And so again, that's not that outside referral. We can just carry them and, get them the care they need right in here with our clinic. What I think community dental care is what's worked best for us. Our business model really benefits greatly from economies of scale. So our ability to, people hear, how are you taking that many new patients all the time? That's crazy. Or how do you absorb all these walk-ins? I'd say we've had smaller clinics when it's, say, only 3 providers. It is a lot harder to do. My hygiene's waiting for me. I got 4 exams to do. So I think what helps is you have to get kind of to a certain size, and what we found in our organization is that sweet spot seems to be about 5 providers working at a time. Sometimes 4 if they're really skilled and their skills or procedures complement each other. One's good at endo, one's good at kids. But for whatever reason, it seems like when we get to about that 5 providers working at a time, we're able to absorb that higher failure rate. We're able to double book appointments a little bit more. We're able to take more walk-ins without burning out our staff, right? Because that's the other concern too. You want to stay busy, you want to help as many, but you cannot burn out your staff. And that larger overall patient volumes also makes stocking of some specialty equipment. The ordering process, how much stuff we order, so if, specialty equipment isn't expiring before we can use it, I think all just benefits from these larger clinics we have. Additional features to consider, community dental care's business model benefits greatly from clinic staff practicing at the top of their license. Again, I don't want my providers on the phone for 30 minutes with the pharmacist. I want them in the clinic helping pull teeth, do exams. So our general dentists that are providing more specialty care, more training in endo, oral surgery, peds, pros, things like that. Our LDAs with restorative function or their local anesthetic certification, so they can, again, do that much more for the provider. Unlicensed, we have a lot of our unlicensed dental assistants that have got their radiology certificate. That has been incredibly helpful to our organization. And again, that adequate support staff. So your clinical staff are doing clinical work, not spending an hour writing a prior authorization or whatever the case may be. Other things that I found are really helpful are to hire for and promote a culture of collaboration and cooperation between providers. We're really looking for not just a provider to fill a seat, which is really tempting when you're understaffed, which we've all been, but really holding out for the right person who wants to be here to serve this community. It pays dividends, even if it takes longer to fill that spot. And the provider compensation model, what's worked for us is our providers are paid on production, and so when they work harder, they get paid more. That's not the only model. It works well for us. And then promote a work culture aimed at supporting the whole employee. So we do in-services on building resiliency with our staff, or about combating compassion, fatigue, and burnout, and being there to really support our staff when they're going through something hard, because as we all know, it is hard to spend your career in the kind of settings we do, so really making sure we're working on that whole employee so we can retain staff that can bring their best selves to work, even if that means they need to step away from work for a little while. And then community dental care benefits from creating and maintaining pipelines. As you all know, hiring is hard, right? Who's looking for a hygienist? We're all looking for hygienists. So ways we're trying to combat that are pipeline grants. So for LDAs and hygiene students, we have grants where they can go to school and come back to work for us and have some of their loans forgiven. I'd say community dental care has a long game. I can't tell the number of dentists now that I've hired that I remember when they came to me as a nervous high school student saying, can we shadow? So just being willing to just spread yourself far and wide. So it's, if that high school student, that pre-dental student wants to come in shadow, come on in. You got into dental school, you need us to collect teeth for you, whatever they need. And that's, we go to high schools, we go to tech schools, we go to, hygiene schools, assisting schools. I speak at a few of the dental schools in the area. We talk to nursing students. And not the goal is not to hire everyone. We'd love to hire as many as we can, but I think the goal is to get as many people exposed to a career in community health. So maybe they won't come work for us, but maybe they'll go work for Apple Tree, or maybe they'll go work for someone else, in which case our whole community benefits. So really being able to just spread that far net, so we're a friendly face, that if you're even just thinking about a career in community health, come right in, we'll show you the door, and just being like a welcoming place for people as far as to start their careers. So, and then I'll let you kind of talk about some of these careers.
So how we really do that is we partner with a lot of different schools, specifically technical colleges, to get that talent before they've even hit their licensure. So we partner with 13 programs across the state, and we see about 300 students annually, and it's in dental hygiene, dental assisting, and then we actually have a program with Century to see their nursing students so that their nursing students are aware of oral health barriers and concerns, so that they're going in to start their service and practice as a nursing student, where they will probably not do much else other than maybe do a fluoride treatment here and there, but know that this is an important component to oral or to whole body health. And then we also then get to potentially hire out from dental assisting or these dental hygiene programs that we partner with when we're looking for new employees. And then I am going to speak a little bit more with our outreach services, partnerships, and care coordination. So I'll kind of go over all of my different buckets, but my programs are to prevent dental disease and improve children's oral health primarily, although I do some other community outreach. So our first one is called Program to Improve Community Oral Health, or PICO is the acronym, and we have in-clinic services for that. So we've spoken before about our health educators, but at 4 of our clinics, we have a full-time health educator that works with families. We specifically target 0 to 12, and what we're looking to do in this situation, and pregnant patients as well, and we're trying to talk about what's actually happening at home. So we use motivational interviewing techniques with these families, and we do those open-ended questions where we ask, tell me what it's like when you are doing stuff at home. And often we're really starting from ground zero. They're not brushing at all, or maybe they brush inconsistently. And so we're trying to see what's actually happening at home and provide them with the tools and resources they need, because we want to make sure that we're meeting patients where they are so that they have the best success long term. And it's really preventative, which is why we really target 0 to 6. But with those kiddos that have a little bit more going on from 7 to 12, then we pull them back in and say, hey, let's talk about the fact that you got 4 cavities at this appointment. What does it actually look like? And we can start with things as basic as, like I said, okay, we're not brushing at all. Can we start brushing 1 time a day? And we give them tools, brushing charts, a new toothbrush. We have the electric battery-operated toothbrushes that we provide. We give them timers. We really provide all of those things. And then we try to hire from the communities that we're representing so that we maybe have someone that speaks that language. So they're out of the chair and they're talking to a face that looks like their own. So it's really kind of marrying those two things to really provide that whole comprehensive preventative education. And we also do that in an outreach setting. So we go to classrooms and we distribute oral health supplies, or we'll just go and table at community events. So we go to schools, but we also go to resource fairs, community events. We really like partnering with early childhood family education classes because we're targeting the whole family, but we're also hitting them when they're really little, and we're doing that preventative education. So we kind of do all of those things as like our preventative educational outreach. And then we also have a couple different service-based programs. So I oversee our school-based sealant program, where we work with collaborative hygienists, and we provide screenings, preventative dental service, which primarily includes sealants placed on those first permanent molars. So we're targeting grades 1 to 3. Occasionally we will see kindergarten depending on the school's need. And we always take referrals from anyone in the school that they want. So if there's someone older that's in dental pain, for sure we will see them and screen them, because we also do that care coordination piece. And then the last thing we might do is a prophy on site for them as well. And we work with 25 metro schools to make that happen. And we also go in before and do, whether they sign up for this program or not, because this is an opt-in program at no cost to the families, but it does require them to fill out a form and provide some information so that we can make sure we can see them, is we would then provide just general education for those targeted grades. So we come in, we give them the basic tools and talk with the kids in those grades, and then everyone, regardless of if they participate or not, will get a new toothbrush, toothpaste, and floss. Because at the end of the day, some of these kids don't have access to these things, or there's a barrier to care for the families to get them. So that's something that I'm very fortunate that we're able to do. And then from what you heard earlier, we have a partnership with Fairview for medical dental integration, which also utilizes collaborative hygienists. And so I'll go a little less in depth in this, but we do screenings, preventative services, the fluoride, the SDF, and then we also do care coordination at the Roselawn and Rice Street clinics. And I'll go more into care coordination in just a minute. So these are our 25 school partners. So we have 2 clinics in Maplewood, so we do have more presence on the East Metro. So as you can see, lots of East Side schools. But we also work with Anoka Hennepin as well, and they are a great partner for us. And what is great is over time we build these relationships with their school staff. So even outside of when we're on site doing this, we have this partnership so they can call us up and be like, I have this kid that's in pain. I don't know where to go. I don't know what to do. And so even when we're not there, we build these relationships so that we're able to identify kids that wouldn't otherwise get access and get them in. And that's where those care grants can come in as well. We can offer that for those kids. Community partners, we have quite the extensive list, but our top 2 would be where we do our medical dental integration at M Health Fairview, Roselawn, and Rice Street. But I also work with St. Paul Public Schools in their early childhood family education classes. Those ones we might do even like language or culturally specific ones where we dive into what the needs of the community are. And so we'll kind of flex to whatever and wherever we are. I recently did a presentation at Centro Tyrone Guzman where they got to really push my Spanish and see how much I speak, which is some, but they had an interpreter there to help me. But like we really try to go and meet the communities where they are, and we have our health educator up in Buffalo who's been doing a great job reaching out to that community and really meeting the needs. It's a slightly different population than we see in the Twin Cities, but she does a great job like going there, meeting the kids, really talking about why you don't need to drink pop with every meal. That seems to be a big one up there. And just kind of building these relationships so that when people don't know where to go, because I think as we all know this like access and where to go, the more places we are, the better equipped we are to actually bridge the gap. And so what I also get to do is bridging that gap. So that care coordination piece, especially when you're going out into the community, often these are people who wouldn't know how to get in the door otherwise. So we will provide that follow-up. We'll help schedule the appointment for treatment. We'll reach out. We'll try to find someone who speaks their language to call and explain. If there's some reason why they're a little hesitant, we will have someone call and explain really why is this important for them. And if there is an urgent need, like we have the ability, as we mentioned, to offer an emergency walk-in and wait, or we'll just look for a hole in the schedule. I can't tell you how many times I reach out to our scheduling managers and I'm like, I have a kid that's in pain. Where can you find me a hole? And building these relationships, both with our staff in clinic, but also with the community. I don't know what the background is of these families and what experiences they've had in the past. So I'm just trying to build that trust. I'm trying to get them to the point where they believe that we will help them and we care about them. And so we need to meet them where they are, which is why we go out into the communities. We build these relationships with our community partners, because at the end of the day, we don't know where in the trust process they are. So it might just be simply calling them back. It might be having someone who speaks their own language call them. It might be, this is a resource that you can utilize and it will help you, and then having it happen builds the trust. We're really focusing on that. We have those programs to support the uninsured and underinsured with the care grant, and then our sliding fee scale, which can be up to 50% off treatment. And so we're really trying to meet people where they are if they don't already have the insurance that they need. And then obviously the end goal is establishing a dental home. Because at some point, some of these families, maybe I just see one of their kids, but there's a whole family that needs access. I can think of a situation last year. I called, I said, hi, I saw your child. You know, there's some urgent concerns. We'd really like to get you in for an appointment. I can offer you a grant. I see that you're currently without insurance. And they're like, that's great, but the younger sibling actually needs it more. So what can you schedule them at the same time? And so I scheduled them at the same time and I got them in. And then I also explained, like, I think you are able to be eligible for medical assistance. Have you thought about applying? And she was like, I never thought about that. And so I think there's this presumption, because we do this day in and day out, that everyone knows what's available to them. But I find even in English-speaking communities, there's a lack of like, what can I do? Or there's mixed messaging that comes from different areas. Like, they just don't know where to go. And so if you can call, you can have a conversation, we can get them in the door. And I see my whole job as establishing that bridge to get them from where they are in the community to our door, because if they can't ever get to us, we'll never be able to treat them. So, and then hopefully they come back for all their preventative and I just get to tell them that they're great and they have great teeth now. That's the goal. Doesn't always happen, but that's my end goal for everyone. So that's our model. Yeah. Any questions?